Hi, my name is Jenny Malcore. I'm going to be your Fireside chat leader. And this is about as much as I want to talk right now. And I want this to be very interactive. So we're not going to wait to the end to have questions. And I've been on the phone with these two last week, and they can talk. And they're going to talk a lot. And it's going to be really interesting. And you're going to love it. But there might be questions in the middle of it. If there is, just raise your hand, and I'll call on you. So I'm Jenny Malcore. I work at Foley and Lardner in government relations. So if there's anybody that needs a lobbyist at all in the future, think of me. And that's the plug I had, my boss made me do, and now I'm done. So
she is good.
Yeah, now I'm done. So I'm going to let these two introduce themselves, and then we'll start with a question. So why don't you go ahead?
Sure. Robert Popovian. I'm with Pfizer Pharmaceuticals. So what I was trained for is absolutely not what I'm doing as a career path. So I have a doctoral in pharmacology and a master's degree in pharmaceutical economics and policy. Hence, I work for government relations at Pfizer. It makes perfect sense, right?
Perfect sense, absolutely.
So what I do is in Pfizer is I work in our DC office in US government relations. My team manages all of our external relationships with regards to policy issues with third parties, as well as I do a lot of policy work and activities regarding healthcare policy and economic issues.
Michelle?
So, hi, good afternoon. I'm Michelle Mettner, and I work for Children's Hospital Wisconsin. I have the honor of overseeing the legal department, the compliance department, and for purposes mostly of this conversation, government relations and advocacy at the federal, state, and local levels. So some of you, many of you may know Children's over in Milwaukee as our flagship hospital. We have 298-bed pediatric hospital. What you may or may not know is some of the other things that we do as a health system. So we've got a hospital within a hospital up in the Fox Valley at Theta. We have all of our pediatric specialists, our Medical College of Wisconsin employees and teachers, and we have about 600 to 650 pediatric specialists. We run 8 clinics ranging from up the seaboard, so from De Pere down to Kenosha and pretty much all of southeastern Wisconsin. We run a Medicaid health plan as well as an exchange health plan, so we've got about 140,000 lives, kids and adults, on our health plan, so that gives us a little bit of a lens into being both a provider and a payer of services. And we have a product for the last couple of years on the exchange market as well. We run the Children's Research Institute on campus as well. So we do about $30 million in pediatric research. We have about 1,000 or so live trials going on. What did I miss? Oh, an important component, which is somewhat unique, although growing around children's hospitals around the country. We operate and run child social services as well. So we're engaged in special needs adoption, private adoption, foster care, home visiting, parent safety, as well as a lot of work, as you'll hear me talking a little bit, around the social determinants. So we have a lot of community navigators and community work as well. So predominantly on the eastern side of the state, although a lot of our social service work and our family counseling work, you'll see child advocacy centers all around the state of Wisconsin.
Great, thank you, both of you. So we're going to start on getting your perspectives on healthcare. I want you to discuss key points such as access to healthcare and drugs, and also the cost of healthcare and drugs. Michelle, if you could concentrate more, obviously, on Medicaid being the state-run, and then Medicare, or Robert, you could be more in the Medicare for all space. Sure. So why don't you go ahead, Michelle?
Sure, so I'll start. So it's interesting, you know, being a children's hospital, we have less than 0.5% of Medicare in terms of our payer mix, but over 50% of the kids that we see are on a Medicaid as a payer. And so that makes for a really interesting financial dynamic. We have a relationship with our Medicaid office like we do with other payers around, commercial payers around the state, where they are our largest customer. But it also brings about some challenges, because I don't think anyone believes that Medicaid is paying its cost of health care, which is, you know, long history of shifting costs to the private sector. And as we'll talk quite a bit, nobody thinks they're paying not enough in health care. So our economics are challenging. I think it's challenging being a specialty hospital, There are both drugs, but other interventions that are expensive, and we are there. We provide the full gamut of services, as you just heard, which means, for the most part, no kid in the state of Wisconsin needs to leave Wisconsin to get care. But the cost of health care is one that we hear about from consumers and that we all need to get a handle on. And when we think about cost of health care, it's the cost to the payers, it's cost to the actual patient families as they're getting more and more sophisticated, as they should, in terms of what is their out-of-pocket cost. It's the cost to employers, it's the cost to government and private payers. So we have a real challenge ahead in terms of how we embrace the innovations and the incredible access that we have to AI and we were talking offline about some of the drugs that we're now able to do to treat kids in ways that we couldn't do before, and the innovation that we're able to bring into the hospital and do things that we weren't able to do before, but how do we balance that against cost? And that is a real challenge that we're all facing. One of the solutions, one of the important criteria I think that we need to look at, and I can say this both as a provider and a payer on the insurance side, is really aligning our incentives as providers around value. And how do we start to align our healthcare system around wellness and talk about investments that we can make in the wellness realm that are less expensive, that are upstream, that, whether we're talking about immunizations and flu shots, or we're talking about, a drug that you give to a woman who's delivered preterm in the past that keeps that baby full term and avoids a $200,000 NICU stay, if not other complications for that child down the road. So realigning, it's not as fast as we'd want it to be, and it's not as slow as the news would report it, but realigning how we as providers are looking at the value proposition of being well and treating wellness for the mental health, physical health, dental health, behavioral health for kids is our focus. How do we bring that upstream and really invest smartly in that population?
So in the federal level, there's like 3 or 4 discussions that are ongoing right now. One has to do with what you've heard is the Medicare for All discussion that is taking place, which is trying to basically upend the entire system that we currently have in the United States. And that discussion in the DC area is taking in many forms. It's taking something of a single payer system, Medicare buy-in, as an option. What you will hear is 50 plus, things like that nature. Now, that's a broad discussion about the healthcare system in the United States and what we have currently. Do we have to change it completely to be able to appease certain constituencies? My retort as an economist has been, even in countries when you have single payer system, you still have challenges with healthcare costs. So if you think that single payer system in the United States will take care of all the ills that we have and the discussion of pricing and healthcare costs will go away, that is absolutely not true. Because you can look at every other country and they are having the same issues that we are in the United States. Now, the second discussion that's happening is about economics of healthcare, which is absolutely something that we need to have a discussion about, because when I started in this industry and working with pharmaceuticals in academia, healthcare costs were about 13% of the GDP. Now it's close to 19% of the GDP and growing. But it's growing for many reasons, good and bad. It's growing because we're utilizing more services. We're utilizing more pharmaceuticals and healthcare services because we're living longer and we're keeping patients alive longer. We're also, because we are, in case of pharmaceuticals, we're also paying for innovation in the United States where other developed countries are unwilling to pay for that innovation. And with that comes the issue of access and whether or not we want to curtail the access. So those are real economic discussions we need to have. Now, in my opinion, what has happened with pharmaceuticals, and let's just micro level on drug issues and drug costs, is a good, healthy discussion, because for the first time in my career, as I said, about 30-year span, we are having an honest discussion of what the pharmaceutical costs are about. And for the first time, people are realizing that it's not just about the price of the medicine. There's a lot of entities, what I call in the cookie jar, that have their hand in the cookie jar and make money off of drug pricing and drug spending in the United States. And with transparency that has come out that, you know, out of the $100 that I sell for Pfizer, I only take in about $60 of it. So $40 of it goes somewhere else. Where that somewhere else is all over the map. And there are a lot of entities that make money, all the way from pharmacy benefit managers to insurers, to hospitals, to physicians, to pharmacies, to wholesalers, to brokers, to agents. It's just amazing when you start opening up the Pandora's box of how many ways. So the question becomes, in the pharmaceutical sector, there are organizations out there, such as you know, Bernie Sanders' group or the Arnold Foundation, that want to talk about individual product pricing and on the micro level. And then there's the discussion about the entire pharmaceutical pricing and spending in general. And we need to have both discussions. But I think it's a healthy conversation to have, because for the first time, we're actually looking at the underlying cause of all of these things. And my comment to people is that when they question about the pricing, is that you can question about the pricing of individual drugs, but don't forget that pricing is influenced by a lot of different things, including the 40% that's lost in the supply chain that goes away, and it's underpinning the entire pricing mechanism and cost mechanism in the United States. So it's a good, healthy discussion. It's something that the United States we need to have. The only thing I ask is for people who are having this discussion, are engaged in this discussion, to also understand that with us paying higher prices in healthcare in general and pharmaceuticals, we get better access, and that's without a doubt true. You know, the two countries that spend most per capita on drugs are United States and Switzerland. And the United States and Switzerland, we have the top 2 innovators in the world for pharmaceuticals, and they're the 2 top countries that access occurs with these newer innovations.
Wonderful. So, asking this question to both of you, what do you think is actually working in the healthcare system right now, and what isn't working?
Well, what's working is, and Robert alluded to this too, is we're having a dialogue that I think we haven't been having before, and some of it is a forcing function from consumerism, and I think that that's what's infused, that's starting to work, maybe not working as quickly as we'd like it to, but employer-sponsored health insurance and consumer groups are really forcing providers and insurers to the table to have a more meaningful dialogue and try to get consumers out from the middle of getting caught in that morass. And I think it's really brought about a real dialogue around wellness. And so, you know, social determinants has been a buzzword for a while, but truly for those health systems that are investing in housing and in, you know, we had a case of a kid that kept appearing in the ED, and we were able to look, you know, at the record and see that the prescription was getting filled, and we couldn't figure out what was going on, but something was just wrong. Well, you know, we realized that that family did not have a refrigerator, and those drugs weren't being stored in a refrigerator. And so while all well-intentioned mom and dad were providing the right drug at the right time, the right place for the kid, it was not a refrigerated drug. So trying to look at the whole spectrum of what a patient, in my world, what a kiddo needs to be well is really, I think, what's working, and the more focus and investment on those factors, I think, is going well. What is not going well? There are a number of things that are not going well in healthcare, and I don't need to tell you, but the inability and hospitals included, the inability to really drill down on what the cost is of healthcare in a digestible, meaningful way for consumerism is not working well. I think we're at a real turning point where we're going to get pushed to really try to figure that out. And provide meaningful data. That data needs to come along with, and we had this conversation a little bit, Robert, that data needs to come along with outcome data. We really, to infuse truly consumerism into a market that has really not embraced and really not had consumerism requires a real look-see at cost and a look-see at quality and outcomes so that folks can make those decisions. And we're not there yet.
So what's working, I think, from the pharmaceutical side, I think it's the innovation. We're truly in the cusp of great innovation in the drug side, and that's because of the advances in sciences. I always explain to people because they're like, oh, you just develop these drugs because you can make more money. And I'm like, no, really, if you look at research and development on the pharmaceutical side, it's driven by science. And I'll point to a paper that was just published by the Schaefer Institute at USC, which, by the way, I'm a graduate, so it's a plug every time that I speak. But in the study, it's an interesting study. They look at new cancer treatments in the United States, and not in the United States, but new cancer treatments. And what they see is that there's an inflection point in 2012 where mean and median life year gained started to increase, that we got better outcomes for cancer innovation that was coming out, oncology innovation. And if you think about it, what happened in 2012, maybe about 5 years before when most drugs are being investigated, is the genome sequencing of oncology, cancer, right? So science is going to drive innovation. Trust me, if we had the science behind Alzheimer's, tomorrow Pfizer would be developing an Alzheimer's drug. We just don't know enough about it. And there are diseases that we just don't know enough about. The science hasn't advanced enough, and mental health is one of them, to be able to do it. But that's what's exciting. That's what's working. Science is driving innovation. Innovation is coming out, and we can do stuff that we couldn't even think about. I talk to a lot of rheumatologists, and they tell me 20 years ago when you walked into a rheumatologist's office, it was a bunch of wheelchairs. And now people are just walking in and out because of the innovation in TNF inhibitors that have come into the marketplace. So what's not working? I think what's not working is that although we want to be more consumer, and we just alluded to that, we want to be more consumer friendly and more consumer oriented, we're not yet providing the tools for the consumer to become better chooser of healthcare services. And if we're going to provide them or put them the impetus of paying for coinsurance and deductible and all these other things, we need to provide them the tools to become successful patients. And we need to, and I think the other thing is that we need to explain to patients why they need to be more actively involved in their disease. I mean, the reason I'm sitting where I'm sitting is because I got so frustrated in my training. When I was in training at the University of Southern California in the free clinic, all you saw is that the same month, every month, the same patient would walk in with the same problem. And it's a free clinic, so access was not an issue, right? They were getting their medicines, they were going home with all their drugs that they needed, but they would come in and it was a diabetic patient, for example, that was in diabetic ketoacidosis, was not taking their medicines appropriately. And it got frustrating that they didn't care. And we need to explain to patients why they need to have a stake, but without information, both on the cost side and the outcome side, that's really difficult to do. So we need to provide them, that's what needs to work better.
I will echo and support what you were saying about the innovation. There are things that are happening now, and my lens is in a pediatric quaternary care facility. There are things happening both with drug interventions and with technologies that simply we weren't able to do, and that comes with a cost. And our balancing and trying to figure out at what cost and who bears that cost is really the dilemma that we need to figure out. The hunger and the interest on the part of the providers for doing these interventions is there. And 10 years ago, if I took you on a tour of the cancer area within children's, you would see a very different pool of patients. Now we've really addressed a lot of childhood cancers, and now we're on to the next. And so that all comes with a cost, and but the innovation that is there is promising and exciting, and we're seeing those amazing outcomes all the time. But getting our arms around what the cost is and what's worthy of a cost when it's your child that needs that highest end of treatment is a real challenge.
Yeah, and the bottom line is that when I started in the industry, we were developing drugs that I can sell to everybody in this room, right? So I can spread the cost across a large patient population. Now I'm developing drugs for you or for you. So the incremental cost for these patients is enormous. And without a doubt, there's affordability issues that need to be addressed. But to say that we're basically having this exponential increase in drug spending in the United States, that's absolutely not true. Drug spending in the United States grew by less than the inflation rate, the general inflation rate last couple of years. So we're not growing anymore, but the problem is that pharma companies want to talk about the macro level, and individual organizations such as ICER and Arnold Foundation want to talk about the micro level. And there are two different conversations. We need to have both of them, but let's not forget that if you're going to take this drug and try to extract the maximum value out of this, first of all, you need to think about whether or not you're extracting value completely from the supply chain. And remember, the dollar amount we're talking about is not insignificant. $160 billion in concessions and rebates and all these things goes back from pharma companies into the supply chain. So if we're spending about $450 billion annually, and we're putting back about $160 billion back into the system, that's about 30 to 40% of it that gets lost. How does that get lost? Is that profiteering? Is that goes back to the patient? Does it go back to the employer? Does it go back to somebody else? We don't know. But we need to figure out both. So if Arnold Foundation and ICER are so interested in the value of this individual product, they should be as interested in what happens whether we are extracting value from the loss in the supply chain.
So both of you talked a little bit about social determinants of health, and Michelle, you said that's kind of a buzzword, and that's true. It's been used a little bit, and I think, Robert, you brought it up when you said in your past life you saw these same people coming in.
Absolutely.
And. So I think I want Michelle, and also when I used to work at the Department of Health Services, that's what everybody talked about, is the social determinants of health, and how can we make sure that they don't keep coming into the emergency room, they don't keep coming into the free clinic. So if you could give like an overall basis of how the social determinants of health could work and how it would maybe work in the Children's Hospital?
Sure. So, we all know, so the breakdown, right? Maybe 10% of your health care is based on going to a healthcare facility and having an intervention. And then you've got the other percentage that's your genetic makeup, and then there's a lot that has to do with your environment and the choices that you make. And if you're a child, the choices that your family or your parents make. Add a layer that I put onto that is poverty, right? And so we're talking about how do we as a healthcare system look at addressing all of what it takes to be well and to be healthy. And so there are health plans and systems that are investing in housing and in remediation in the homes and dealing with lead paint issues and dealing with cockroaches in homes that spark an asthma attack, and looking at what's the prevalence. We are inundated in a great way with data. And so how are we then now looking at the data of who's coming into our ED, why are they coming? Why are they coming back several times, as we were talking about? And what really is the issue? So social determinants is really saying, okay, then what can we do? And again, I go back to aligning the financial incentives to encourage systems to look at it this way. Insurers are encouraged to look at it this way. What can we do upstream to be addressing all of those other factors, whether it be electricity in the home, or a refrigerator for drugs, or kids being able to get a healthy breakfast to start their day? What are these other factors that are posing barriers to health and wellness? Access to dental care. So health systems, children's hospitals, and many others in this state and around the country are looking at, okay, what can we do? Where can we meet the children where they're at? Can we do dental screenings in the school-based system? Can we put school nurses across in schools? Can we do more with mental and behavioral health? We're seeing signs of depression and anxiety on kids that are younger than 5 years old. What can we be doing out in the community where people live, breathe, work, play, where we can have interventions that may not be as costly as walking into the ED at Children's Hospital, And how do we go upstream to invest in that kind of wellness? And early on in my career, particularly when Children's was a hospital, I would say, boy, we're really arguing against self-interest here, right? We get paid for kids to be in the hospital. That's how we get paid fee for service. And now I think health systems can start to look at the global payment and say, how can we more smartly invest in these other factors that might keeps kids out of the hospital?
So incentives matter, and I'll give you guys a perfect example of how social determinants of health. So ACA passed. Oregon was one of the first states to sort of expand the Medicaid program. A study came out about a year and a half, 2 years later in Oregon that despite expansion in Oregon of Medicaid through ACA, the number of emergency room ED visits actually didn't drop, and it went up. So the whole argument was, wait a minute, we're now giving these people insurance, why are they showing up at the emergency department? Then you start peeling the onion and you realize the majority of these patients are poor patients who are employed, but their employment is based on hourly wages. Mm-hmm. So they are not able to take off in the middle of the day. Some of us have that flexibility to go see a physician. So it ends up being that they end up going to the emergency room more often. Now they have insurance, so the insurance is paying for it, but before they were going as uninsured, right? So in other words, we've given them insurance, but we haven't changed the ability for them to access medicine a different way. So my argument was, you allow them to have physician office hours after the normal hours. So that will reduce the emergency department visits, right? Not giving them just insurance through Medicaid expansion. And I'll give you my own real world example of a friend of mine who's a urologist in San Antonio, Texas. So Johnny was basically a fee-for-service urologist for decades. You know, he's an older guy, he's been around. So he was put on a capitated system. So he was paid a lump sum to manage all the care of his patients. He goes, Robert, as soon as I was put on a capitated system, you know what I did? If a patient called and I knew it was a kidney stone, when I was in fee-for-service, guess what my answer was? Go to the ED. You know, I'm done. I'm not going to keep my staff here. When I was capitated, I kept my office open because I knew if he ended up in the emergency room, it would hit my cap dollars. What else did he do? What is the number one thing urologists do is PSA screening, right, for males. So he used to send the labs out of his office. The cost was $100, I think, for each lab. So when he's capitated now, that capitation, he has to pay for it out of his lump sum money for that lab amount, right? So he called Abbott Laboratories that made the PSA kits, and he asked them, he goes, how much is it for me to buy this machine to do the labs in my office? And they're like, how much it costs? It's free. We give you the machine. He's like, oh, then what do I need to, he needs to buy the kits, right? So how much are the kits? $5. So all of a sudden, his cost structure went from $100 a lab test to $5 for the kits. So he goes, you know, I was a nice guy and the lab was right down the hall, so I decided to go tell the lab, you know, I'm not going to give you business anymore because that's the majority of the business is going from his office to that lab. So he went down in the hall and the guy goes, you know what, I'll change my price. I'll do it for $20. So all of a sudden it went from $100 to $20 without him even doing anything. That tells you how much fat there is in the system, that people still can make money by doing it at $20. And my point being is that when you change incentives, people's behavior changes. Same thing has to happen with pharmaceuticals. There are certain drugs in our portfolio right now that we need to put where our mouth is, our money where our mouth is, and say if it doesn't work, you don't pay for it. And that's why you hear buzzwords like value-based contracting, outcomes-based contracting, and we need to partner up with individual organizations such as Michelle's and say, okay, if you take this drug, this is the outcome you should expect. And let's work together to collect that data. Now, this is not the panacea for every single drug in the world, right? This is a select number of drugs that have a determinant outcome measure that can be done over a period of time, and there's no market competition to drive down their prices. It's single source, brand name drugs primarily. So we need to do more too. and take on the risk as individual pharma companies, as patients need to take on the risk, as providers, as hospitals and insurers, and so on and so forth.
Wow, very interesting. I think we have a couple more minutes. Okay, are there any questions? Yes.
So do you guys find that, because we're talking so much about innovation in these hospitals, do you find that insurance companies impede on that innovation a little bit in terms of when we were talking with the keynote speakers this morning, talking about having AI with a lot of these machines that we use daily? Do you ever have insurance companies look at you and it's like, well, the other one works just fine without AI, why would we pay for the one with AI? So do you think that that has impacted the way healthcare is because these insurance companies are not willing to pay for the better quality equipment?
Yes and no, and it varies across different insurers, but the ramp up for the education of what the intervention can mean and the value return on investment is an education process that goes on every time that we're contracting for services and getting denials for things because they're saying, well, that one's good enough. And we were talking a little bit before about the price structure. If you're looking at the entire price structure of what the value outcome is of a new AI intervention as opposed to the way we've been doing it, the price might look like it's too much for an insurer. If you sit down and you say, okay, but how many times does that patient need to come back if we're doing it this way versus doing it the way we've been doing it? Look at the entire bundle of what that cost is. And I would say there are some insurers that are farther along at their willingness to look at that, but they're looking for the proof first, and so it makes it really challenging to get those going. We rely heavily at Children's on our philanthropic arm to allow us to start doing things and then make the case and then be able to go with the data to the payers to say, look, share in this investment or share in these savings because we're doing it. But without that philanthropic support, it's hard to get that dialogue going.
I think in the pharmacy side, on the biggest problem we have is the pharmacy benefit managers because they have no risk, right, on the health outcomes. Basically, they can do whatever they want to do with formularies, and if the patient is rehospitalized, they're not on the hook. Now, that's going to change now as a lot of them are becoming more of an insurer, so that should be taken care of. But ultimately, the person that needs to be watching all of this is either employers or individuals. Employers, because ultimately they're the ones who are paying for it, and they need to demand that type of behavior change on their behalf, that they appreciate the transfer of risk across the board.
Yep, go ahead.
I think the traditional risk management in hospital setting for the accountable care organization is overutilization of the ED and payment management. But with the advent of gene and cell therapy, such as CAR T, become more and more expensive. For CAR T therapy alone, its cost of $35,000. Then you add that to emergency care, you add that to the clinical fees, it could run up to $700,000 for one case.
Yep.
Now that's before it's being submitted to the insurance company. The insurance company can choose to pay, not to pay portion of it, or negotiation price. I guess today's panel we have such a good representation of the drug industry, and we have the hospital ACO representation. But is there any internal discussions of how to deal with upcoming new challenge, the high personalized medicine costs of pricing? How to deal with de-risk?
So I can address the CAR T issue because that's a perfect example of an outcomes-based contract that the pharma company can engage in, right? Because there's definitive period of time you will see the outcome. The pharma company can basically work with providers in the hospital setting or even a medical group and things like that to collect the data, to follow the patient, to see the outcome, and if it doesn't work, then they'll pay for it. We've been doing this type of work, by the way. Pharma companies have been doing this type of work in Europe for years and decades. And my boss asked me when I started, why haven't we been doing it in the United States then? Because we didn't have to. When you don't have to, you don't do it, right? Now we have to. We have to have more unique type of circumstances that we partner up and do the risk. In fact, our former CEO's grant plan is ultimately to pharma companies to work directly with like hospital groups or work directly with medical groups that take on the risk together rather than having to go through this whole supply chain of insurers and PBMs and everything else. And we can do that now because you mentioned CAR T, right? CAR T is not going to be used for a lot of people. It's just a few patients here and there, so you can manage that risk. We're in an era that these drugs are not being used for the masses, so we can manage the risk much more easier.
I think it's a really good example of what is happening and needs to happen more. It's harder to manage the risk if you're a specialty hospital and you are seeing 5 of those cases that are rare and you're running up those kind of costs. And so those are the conversations that we, along with the pharmaceutical companies, are going into insurers and saying, you know, this is the cost. How do we cover it and how do we manage it? And those are the conversations that, as a payer of Medicaid, that I'm going in and having those conversations with our state's Medicaid department all the time. Every time we see a new drug come on from the FDA, you know, years ago, we didn't have a lot of drugs that were, you know, the orphan drugs or innovations for these small populations of benefit. It was certainly not worth the investment, and it just wasn't happening. Now it's happening, but to the earlier conversation, you know, there's such a few population to spread that cost over that the costs are extraordinary. And so it really is incumbent on us to have those conversations with the insurers, to your question, with Medicaid, in partnering with those that are innovating and saying we need to collectively figure out how we get that covered.
Do you have time for one more? I had a question up there.
Okay.
Okay, so let me address the first part, which without a doubt, I think capping pricing, depends on how it's done, will have an impact on R&D, research and development. So research and development funding for pharma companies comes from revenue. Price is part of the revenue structure, right? Because revenue is a combination of price to utilization. So if you are going to manage pricing, what you're going to do is impact revenue. Now, if you cap prices, whatever the HR 3 is recommending or the Senate Finance Bill is recommending, is that going to impact Pfizer from investing in R&D? No. But is it going to make us decide what we invest in? Much more scrutiny on drugs? Absolutely. So I'll tell you the answer I gave somebody recently who came to our office about, well, tell me exactly how many drugs are going to be impacted. I said, I don't know, but I can tell you it will be impacted because there is a correlation between revenue and innovation. And anytime you would touch prices, which is part of the revenue, it will impact it. Is it a one-to-one correlation like people want to make it out to be? No, probably not. But there's no doubt it will be impacted. Now, what's going to be impacted? It will probably impact areas that are understudied, mental health, Alzheimer's, things like that nature. It will impact also drugs that the commercial value is not going to be super high, right? It's going to be things that are for rare diseases and small populations because of uncertainty of recouping your revenue. So Pfizer has a drug like that in our portfolio. We invested heavily into a drug called Xalkori. Xalkori is a lung cancer drug that impacts 4% of the lung cancer population. If price inflation caps would have been in effect, we would probably not invested in that because the population wouldn't be big enough, and we knew that there were multiple competitors coming into the market after us that is going to drive down the pricing. So to answer your question, yes, it will impact it. Is it going to be one-to-one correlation? Probably not. But what we need to do is be aware of it, that it will take a wrecking ball into certain areas of research that we currently are investing in. But that's, as a society, that's a decision we need to make. Because I always go back to, I'm more of a libertarian when it comes to these things. And my thing is like, look, as long as we know the risks, and the risk of price controls, where risk of investment in drugs is going to impact innovation, and we're willing to take on that risk, that's great. Let's do it. I'm all for it. But don't come to me 10 years from now and say, oh, how come we're not investing in research and development in mental health, where the last mental health research and development breakthrough drug was when I was in undergrad in the 1980s. That was really when we were doing all the scientific research in it. So as a society, we need to make a decision on that and move forward. I think it's dangerous, but.
It's a great answer. I think we're out of time, but I want to thank these two very much. Give them a big round of applause for being here.